we managed to collide our calendars this year. And actually, I think my HHT cohort has probably tripled in the last year or so. So
that's what's happening.
Yeah. So I guess I also look after patients with haemophilia, and it's interesting that actually the incidence of both diseases is the same. It's 1 in 5,000, and so that I kind of have a good representation of rare diseases, I guess, would be. But as I said, not so rare for me. So I, from the questions that Dara sent me, I guess the thing that sort of seemed to crop up the most from a haematology perspective was the anemia, iron, and management of those things. Some of the questions that I mightn't have addressed specifically in the talk, I'm happy to answer questions on, but hopefully, and I based the talk along the HHT guidelines, because I think that's actually the best place to look for evidence-based recommendations as opposed to non-evidence-based recommendations. We'll go with that. So we'll start and we'll see how we get on. So I guess in terms of the recommendations, and you're no strangers to this, but every person who has HHT, adults and children, need to be tested to see if they are deficient in iron. Now you may also be anemic, and we'll look at that in terms of the levels of deficiency, but just because you're deficient in iron doesn't necessarily mean that you're anemic, and if you're anemic, it may not always be due to iron deficiency, and so it is important, and as you know, I mean, the recommendation is that all adults are screened for anemia, and we'll discuss how. We don't tend to test children unless they're bleeding, because it's not fair to do blood tests on children, and I'm a very firm believer in that you should not be doing investigations on children unless they need to have them done. And I'm not a proponent of a once daily or once yearly blood test for children if they're not having any problems. And there will always come a tipping point, which we'll discuss. So I guess people say, how much iron do you need? And it's a profit and loss, it's an accounting thing, it's a balance sheet. You have to take in more than you're losing. And every single person in this room will lose a different amount of iron and will take in a different amount of iron depending on their diet and how much they lose. Clearly women are always going to be more at risk of a negative balance because of the fact that they have periods from when they're potentially 12 to 50, give or take, and also because they often will have pregnancies, and you lose an average of between 300 and 500 mils with every pregnancy at delivery, and never mind what the baby takes. And so women are always more likely to run into trouble with iron deficiency, much more so than men. But obviously with HHT patients, if you have significant epistaxis, then clearly that is going to cause your iron stores to be depleted. And if you're bleeding, you're going to need to take in way more iron than someone who has a nosebleed every 6 months or so. So as I said, it has to be, so there's no answer to that question, but the answer is very obvious. So the daily requirements, and apologies actually that's between small and whatever, but so you can see here actually that the average is about 8 milligrams, 9-year-olds 8 milligrams here in pregnancy, and women obviously need way more. They almost need twice as much throughout most of their lives, most of their reproductive lives. And so it's important that we always remember that. How do you diagnose anemia? What are the actual tests that we do? And there are 3 different types of tests, and depending on the laboratory in the hospital will often determine where those tests are done. And sometimes if we're like, well, the sample went to the wrong lab, or we took the wrong sample, or we did X, Y, or Z. But the most important test, in my opinion, is the ferritin. The full blood count obviously will tell you whether you're anemic or not. 13 is my cutoff for everyone except children, because I don't feel that women deserve to have a lower hemoglobin than men. So I'm like going, everyone should have a hemoglobin, give or take, of 13. That, in my opinion, is normal. And if you're above 13, you're normal. If you're below 13, you probably need a bit more iron. The ferritin, in my opinion, should be above 50. That's my number. We say 30 in pregnancy in different documents. And if I have someone who's bleeding a lot, I actually push for a ferritin above 100. I'm not happy with 50, because you always need that little bit of wiggle room when you're bleeding. You need to have that if you get a bad bleed, that your hemoglobin is going to drop like a stone. People are like, well, what's the difference between iron studies? So iron studies are a combination of measured tests and calculated tests. So the measured tests are your serum iron and your total iron binding capacity. And what you do is you divide the iron by the total iron binding capacity and you multiply it by 100. And that actually gives you what's known as a transferrin percentage or percentage saturations. And 20% is the number there that we want to be above. Now, the caveat to that is if you take your iron tablets that day or the morning or an hour before you have your blood test done, then your iron level is going to be higher, which means that calculation is going to be falsely abnormal. And so it's a useful test at times, but unless you have another chronic condition or heart failure or kidney disease or an inflammatory condition like arthritis or something, normally the ferritin will actually give you the information that you need. It'll either be low or it'll be normal, as we say, above 50 or above 100, depending. The CRP can be useful, and a CRP is a marker of inflammation in the body. If your CRP is normal, your ferritin result is accurate. If your CRP result is abnormal, your ferritin may be falsely elevated and it may look better than it actually is. In that situation, we tend to use the iron studies and that percentage of 20%, because that helps us to determine, right, is the actual stores in the body, is the usable iron that's available to us, is that actually going to be able to be mobilized? And that's where the iron studies come in. So depending on the test, but the ferritin really is the number that you're always more interested in, and I'm sure you all will have ferritins of 2, 3, and 4 at various times. Competition for how low can you go. And so, but in general, what you're aiming for is above 50, it provided you don't have anything else going on, and sometimes, as I said, above 100. So the anemia, as I said, children tend to have a lower hemoglobin, especially toddlers, that kind of age group. They tend to have a lower hemoglobin, which is why, as I said, unless they're having trouble, and usually they don't at that age, we don't tend to be checking them. So this is what I was alluding to in terms of your storage iron and in terms of reflecting whether you're anemic. So this here is someone who has a normal hemoglobin, normal iron stores, and they have a normal ferritin and normal transferrin saturations. They're able to use all their functional iron with nothing wrong with them. This person here then has their iron stores are gone, and you can have low iron stores but not be anemic. But that doesn't mean that you won't necessarily have symptoms, and you can like a bit of ice every now and then, or you can have your legs jumping in the bed at night, or you can have brain fog, or so it's various different symptoms that people, and everyone is a little bit different in terms of their symptoms. What one person might have, another person would be like, that's not due to iron deficiency, I never get that. But that's the individuality of life, thank God. And so I guess once your iron stores start getting depleted, you may get symptoms, but people may say, oh look, they're on again about the iron and the iron and the iron. And actually you're right, and that's when your oral iron intake needs to increase to try and stop you getting into the next stage, which is where your ferritin is actually low. Oh, now what am I after doing? Anyway, you see now why the talk wasn't done on Wednesday. And so you can see here that this is where your ferritin starts to fall. And then this is where this one here is where you're anemic. So you've no iron. And this is why sometimes you might find, you wouldn't have had necessarily a very bad nosebleed or bleeding, let's say GI bleed or wherever the bleeding came from. But your hemoglobin went from being 10 2 weeks ago down to 7. And you're just like, why did that happen? The bleed wasn't the worst one I ever had. And it's because your body is not able to mount the response. And you need to be able to make red blood cells. And if you can't make red blood cells, then your hemoglobin is going to drop like a stone. And it's like, but I didn't even bleed that badly, and what's going on? Is there something else wrong? And so that's why, as I said, having your iron stores all the time, and most patients, I'm like, don't ever stop your iron. If you can tolerate your oral iron, keep taking it, because that will keep you out of trouble. And it will allow for the losses that we have normally every day, as well as any additional losses, without you ever getting into negative equity. And see here, this is where you have a normal hemoglobin. You have normal stores, you have normal ferritin, you have normal everything. And as you go, your hemoglobin starts in iron deficiency anemia, you can see that everything is low. You can ignore that one there. Your ferritin is very low, 5, 6, 7, 10, 20. It doesn't really matter, as I said, once your hemoglobin starts to fall. But you can see here, this is where the only test that might be reduced is your ferritin. And then as you become more iron deficient, your iron studies, your transferrin saturations, everything else, your serum iron, everything will be lower. And so we want to try and avoid all of these situations by keeping a close eye on the ferritin to make sure that we're always above 50 if we can be. So as I said, everyone is different. Some people need monitoring every month, every 2 weeks, because of the fact that they're always in this precarious balance. Other people may actually only need bloods done once a year because they're actually able to manage, and they kind of know, okay, if I do this and I do this and I do this, then actually my hemoglobin will stay good and my ferritin will stay normal. So as I said, maintaining your ferritin above 50, transferrin saturations above 20 and a normal hemoglobin. And how much you need and how much monitoring you need depends on how much iron you're losing. Avoid triggers, and everyone knows, I mean, I guess alcohol is probably one of the bigger ones, but I often find, and I've discussed it with lots of my patients, coming into the summer season, it's hay fever, it's pollen, and then the nose gets all runny, the eyes get runny, then the nosebleeds get worse, and it's like, okay, if I can just manage that a bit more aggressively, maybe with an antihistamine as well as coming into the summertime, that might actually help to make my nose not get too inflamed so that the nosebleeds don't kick off. And again, it's a little bit different for everyone. But it also makes sense, particularly as a woman, that you try and minimize any other blood loss. And so if you can turn off any other taps that might be on, then it is much better to do that, because that obviously will stop you losing additional blood, and therefore it will mean that your iron requirements will be less. And so if your family is complete, you might consider a coil, because that will actually stop your periods completely. You can get it changed every couple of months, and it also means then that if you needed HRT in the future, that you can use the coil as the source of progesterone with the estrogen topically as your estrogen, and so it's a much safer way of doing that. And so for multiple reasons, I think people think I actually have shares in the company that make them, which I don't. I wish I did, but I don't. And then the other game changer for a lot of patients is obviously tranexamic acid. And tranexamic acid is a medication, and obviously I know cyclocaprin is there, and it has been very difficult to get cyclocaprin, the brand name. But with drugs like this, once a drug has been made for more than 15 years, it becomes generic, and the chemical composition of it has to be the same as the parent compound. And so the tranexamic acid you get that says tranexamic acid is fine. It doesn't have to be cyclocaprin, and I know people can get stressed trying to source it, and it costs more money and it won't be covered and various different things. But whatever tranexamic acid it is fine. Up to 8 tablets a day is the dose that can be taken, but as I said, it's another real individual thing. Some people find 1 tablet morning and evening is enough. Other people need the full whack, full 8 all the time. People ask about the side effects of cyclocaprin, and yes, there are some, but actually they're usually very obvious. Some people feel a little bit nauseated, but often those side effects, you kind of accustom and acclimatise to them and they disappear. But what I would say is that people are always worried about the risk of clotting on tranexamic acid. And it's funny how this drug has kind of not come into favour, but I think people realise that it's a really, really useful agent. It's used in a trial of 20,000 women in Africa, India, Europe, America, in women who were bleeding after delivery, and it was given. And there was no increased risk of clotting in those women. It's been given to people who've had bleeds in their brain worldwide, and there was no signal of clotting. And those trials had more than 20 and 30,000 patients in them. So we know this medication is exceptionally safe, and it works. And so people sometimes will be like, oh, I heard or someone said that you can get a clot. We can all get clots, and the problem is just because you get a clot and you were taking cyclocaprin doesn't mean, or tranexamic acid, doesn't mean that the tranexamic acid caused the clot. And so we have to be careful that we're not ascribing or assigning blame to a medication that actually I think is probably the cornerstone of treatment for most patients with HHT. And without it, I know my job would be a lot more difficult. This is just the patient information leaflet that's available for in terms of the next recommendation, what type of iron is IV better than oral? And so categorically, the answer to that is no and yes. So no if you can take oral iron. Oral iron, if you can tolerate and if you can take sufficient oral iron to prevent your ferritin from dropping below 50 and to keep your hemoglobin normal, is the treatment of choice without doubt, day in, day out, all night long. And clearly, if you cannot tolerate oral iron, or if it doesn't work, or if you have such high requirements that you couldn't possibly take enough oral iron for you to ever be able to maintain your hemoglobin and your ferritin, then clearly it's not sufficient. But it doesn't mean that you don't necessarily need it. It just means that you might need an oil boost every now and then to keep you on the straight and narrow. But it doesn't mean that you should stop the oral iron because you're going to be taking it. Yes, maybe for a short while you can have an iron break. But then if you need it, you need to go back on it again. Otherwise you will need more IV iron because your hemoglobin will fall. And so it's not that IV iron is better. Yes, it works more quickly because we can give a higher dose. But actually sometimes, as I say, the tortoise always wins over the hare. So just because you can do something faster doesn't necessarily mean that it's better. And so I would say that oral iron is the treatment of choice, but in patients for whom it's not effective, not absorbed, or not tolerated, or in someone who presents with severe anemia, clearly you need to do something to help bring the hemoglobin up a bit quicker, and that's where intravenous iron has revolutionized treatment for multiple conditions, not just HHT. So, oral iron, which preparation? You take the preparation you can tolerate. So there's no point in saying you have to take Galfa or you have to take Ferrograd C if you actually are so nauseated you can't even look at food or whatever, or your husband or your wife. Take a daily, really, yes, technically iron may be better absorbed if you expose the receptors to it every second day. But sometimes we don't have that luxury, and you need to take more iron than every second day will allow. And so it really does depend on, if you find taking 2 iron tablets every second day is easier on your tummy and on you than taking 1 every day, then absolutely try every second day. But just because you take it every second day or every day doesn't mean it won't work. You will absorb it. And paradoxically, or probably our bodies are so clever, the more iron deficient you are, the more iron you will absorb. So if you're not that iron deficient, you won't absorb as much. If you're very iron deficient, you'll absorb way more because your receptors get upregulated, and so therefore you're kind of going, okay, I can absorb it. And it says there, normally about 2 to 3 milligrams of the iron, so of the tablet. That's why your bowel motions go so dark, is because of the fact that most of the iron goes down the toilet, not actually you don't absorb it. But actually that absorption is increased about 3-fold when you're severely iron deficient. And so that's the reason why, as I said, the oral iron will work, because you need it more and your body knows you need it, so you will absorb more when you need it more. As I said, the elemental iron content is critical. And you know, spatone and all of those other wonderful preparations that are they have tiny amounts of elemental iron, sometimes 5 or 10 milligrams, and you're actually wasting your money buying them, because actually you'd be better off probably having a steak, I'd say. And so, but it is important. Now, I will caveat that by saying, I guess active iron, I think for people who have iron intolerance, if you can afford it, unfortunately, because it is considered a supplement, it is not a medication, and therefore it is not covered on your medical card or in any of the payment schemes, because it's not considered a medication, and the company that make it probably don't want it to be a medication because they want to charge more for it, and it is very expensive, and I am acutely aware of that. I mean, it's about 25 euros for 30 tablets, so you really, and it's about got around a third of the iron content. And so, as I said, that's where if you can take a Ferrograd C or a Galfer every second day, you're way better off doing that than you are trying to take or pay for some of these other supplements that are much more expensive. And talk to your chemist, you know, as I said, the pharmacist will really help you and help you pick the one that's right for you, and that's the cheapest. And obviously most of them will be covered on medical cards, but the supplemental ones won't. Taking it with vitamin C increases the absorption, but you don't necessarily have to get the vitamin C in the tablet. You can take separate vitamin C tablets, or you can take orange juice or whatever you fancy, but it does increase the absorption. How do we calculate the dose of iron? And I'm actually going to skip that, but is which iron formulation is best? And I'm going to discuss this because actually Dara emailed me something, and it was only afterwards that I realised what actually was being referred to. And so the iron formulations that are available in Ireland, there were 4. So the first one here, Cosmofer, when I started giving IV iron about, 10 or 15 years ago, we only had Venofer. Cosmofer then came in, And it was a bit tricky. You had to give the loading dose over 45 minutes, and it was a bit foostery, and you had to be calculating all sorts of things, and it wasn't easy to give, and it had to be given over a couple of hours. And so it was grand, but it was just, everyone kind of was a bit fed up of it. Then Ferinject was the first intravenous iron preparation, which is ferric carboxymaltose. And this was, you could give a max of a gram at a time. You had to give a small, you didn't have to give a test dose, and you could give it over 30 minutes. And so this revolutionized iron therapy in hospitals, because if you think about it, before you'd have someone on a seat for 6 hours, now you could have them on a seat for 30 minutes, and it's like, job done. You can give 5 times the dose of Venofer in a single sitting in half the time. It was like, hallelujah. But obviously it came at a cost, in that the companies, it was about 1,700 euros when it came out first, a dose. And so it was horrendously expensive for something that actually there's very few indications for in real terms at the time. Then Monifer came out, and this was better again. And the main reason it was better again is that the infusion time was shorter, and you could give more in a single dose. So you could give 20 milligrams per kilo. And so for an 80 kilogram man, you could give, actually it was capped at 1.5 grams, so you could give 1.5 grams, which meant you probably didn't need to give another dose. And so you get away with 1 dose, back on the roll if they tolerated it, and job done. 200 milligrams of iron given intravenously is the equivalent of a unit of blood or a gram of hemoglobin. So if you give someone 1,600 milligrams, that's the equivalent of raising their hemoglobin by about 8 grams, or building up their stores. And so normally that kind of a dose, if you can try and manage the blood loss, you shouldn't need to keep redosing. But what was found with, so every hospital has their own rules, and they have their own suppliers in terms of medications. And so in Galway, or in GUH, we use Monifer as our main iron preparation. We use Ferinject in pregnant women because we had 3 episodes where the baby's heartbeat slowed when a woman was getting intravenous iron with Monifer. And so we had to make a risk assessment of the situation, and one of those women was, they were all 3rd trimester because we try not to give iron too early, but it potentially could have resulted in the baby being delivered early, and we felt that we couldn't stand over this. We had looked at other hospitals and what they were doing, so we had chosen to use Ferinject during pregnancy as a single dose, but we use Monifer for all other populations. And the reason that that's important is that it has now emerged that ferric carboxymaltose, or FCM here, causes upregulation of a receptor which regulates phosphate metabolism and vitamin D metabolism. And what has been found is that this protein upregulates this receptor, which causes you to lose phosphate in your urine. And it also limits your capacity to reabsorb phosphate. And so it can cause you to get a severe deficiency of phosphate, and ultimately what's known as secondary hyperparathyroidism, where you get a low parathyroid hormone and a low vitamin D level, and you can get problems with osteomalacia and and so with your bones. And so it has been recommended, and I know you probably can't see it very well, but it's been recommended that you, if you're going to use an iron preparation, you try and not use Ferinject essentially. If you have to use Ferinject, you should check the phosphate level. If your phosphate level, which is one of the salts in your blood, is normal, then you can give the Ferinject. But if your phosphate level is low, then you shouldn't give the Ferinject, and you should either get a different iron preparation or not. Now, it's funny, when Dara sent this to me, I was like, oh jeepers, I actually there's a few chapters in the medicine book that I actually wasn't very good at. And
sorry about that.
And as I said, or that I didn't do as a kind of an undergrad, as a postgraduate. I never did endocrinology medicine, and so I'm fine. I can manage stuff, and I know what to do in the kind of the ABCs. But if you get me down to Z, I'm very bad at the Z part. And so I was looking at this, going, oh my God, that's I think what was being kind of alluded to. And so I have actually sent Dara this article, which is a medical article from the American Society of Haematology presentations in December of last year. And I'm happy for Dara to send it on if anyone needs it specifically for their doctor, because it is something that if you don't use this preparation of iron, or if your hospital doesn't use it, you may actually not be aware, or your doctor may not be aware of it, because there is so much information everywhere, and it's so hard to keep up to speed with every single area. and we all tend to focus on the things that we need to know for ourselves, and we don't tend to read outside our own worlds. And so, but it may be that is what I think that person was alluding to.
Sharon is in the room. Sorry, Sharon.
It's actually me at the minute, so
Okay.
it's really interesting to see, because the phosphate levels.
Is that, did you get Pharinject?
Yes. For inject, and I had 6 12 RNAVs of phosphate that didn't come up.
No,
but
it
now my
doesn't work.
parathyroid is really high.
Yeah, you've got secondary
And-
hyperparathyroidism. I'll chat to you afterwards.
Yeah,
Is that all
that's
right?
great, thank
Because
you.
and I've sent Dara that article, and as I said, it is tricky to treat.
Yeah.
But I think at least you know.
Yeah.
But so I
Thank
think
you.
this is what you were. I
Yeah.
think this is what it is.
Yeah, great.
So recommendation number 3, and this question came up a lot, is when do you need blood? So we're really mean with blood, to be honest with you. We give it to no one. And the reason we don't transfuse patients is because if you're deficient in something, it clearly doesn't make sense to give you something else instead of what you're deficient in. So if you're deficient in iron, give iron. Why would you give blood? It doesn't make any sense. So there's 200 milligrams of iron in every unit of blood. And every hospital has a policy in terms of why and when should you give red cells. So you give red cells if someone is bleeding so much that they are what's called hemodynamically unstable. So if they have a low blood pressure, if they are anemic and they are bleeding, you give blood. You give blood if someone, despite iron, folate, B12, everything you're doing, is still anemic to a point that they're exceptionally symptomatic, and usually the cutoff is 7. It's between 7 and 9, depending on if you've got underlying heart condition or not. So this is the reason that we give it, or if God forbid you needed an operation and your hemoglobin was very low. So those are the situations. It tends to be gastrointestinal bleeding or severe epistaxis. Those tend to be the situations, and it's often on a background of chronic blood loss. And so otherwise we won't be given blood. And so we have very specific requirements and protocols for transfusion. Now, in terms of the side effects of blood, the commoner ones, so reactions to red cells, are now much less common, because we remove the white cells at source. We pass it through a filter, and the white blood cells are the things that cause most of the problems, and they're removed. And so it's what's called leukodepleted, and all blood in Ireland has been leukodepleted since the mid-90s. Antibody production, antibodies are proteins on the surface of your red blood cells. If I give you someone else's red blood cells and you don't recognize the proteins on the surface of the red cells, your body goes, holy moly, what's going on? I'm going to get those red cells, and it makes an antibody which destroys the red cells that you're given. Now, it doesn't necessarily do that the first time you get the blood, but when you get blood again, you're at risk of having what's known as a transfusion reaction. And so what we try and do is, that's one of the reasons why we try to minimize transfusion, is because we don't want you to get an antibody, because it makes it much more difficult to find blood for you the next time. And so it's called alloimmunization, and it's the reason that we have to take the samples and we have to send it to the blood bank, and they have to check your name and scan and all of that, any of you that have been transfused. But we are stingy enough with blood. We'll give you 1 unit, we mightn't give you 2, we'll check it again, and then we'll give you iron, and that's what we should do. So we try not to give transfusions for iron deficiency, because it doesn't actually treat the problem. You're still going to be iron deficient after you got the blood. You might be a tiny bit better off. And so, as I said, some people though have multiple other conditions. So they might have heart failure, chronic kidney disease, inflammatory conditions, and their hemoglobins may not respond to iron as well. And so it's more likely, unfortunately, the older we get, that your blood in your bone marrow doesn't necessarily work as well as it does when you're bleeding chronically. And so sometimes in that situation we might be a little bit more generous with the blood, but not much. And so, as I said, iron overload is a side effect of transfusions, but chance, as I said. So I don't think anyone getting blood for HHT will ever have issues with iron overload. I guess if you know why someone is bleeding and why their hemoglobin is falling, then you can go, okay. But if you're not sure, and if there might be another cause, you have to assume that we can get the same conditions as everyone else. And so if you're bleeding from the bowel, you have to make sure that there isn't a cancer there, or you have to, so it's okay. And once you do that test once, you'll be like, I'm not having that done again. It was fine last year, thanks very much, you're grand. I don't need an endoscopy or a camera test. And so, but they will insist, and rightly so, that you have the test done if you're bleeding, because we need to visualise what's going on and make sure that we're not missing something else. And so if you're not responding, or if the bleeding seems out of proportion to your blood counts, etc., it may be that you'll have further tests done. But we don't do that in everyone. Like if it's obvious, and if it walks like a duck and talks like a duck, and you're bleeding from your nose and you're looking at everyone going, yes, that's where it's coming from, then we're not going to start doing camera tests on you because you've got a low iron level, or the periods are heavy too, or whatever. So it's important, but always think of that in the background. You know, as we get a little bit older, you might be referred for the camera tests, and don't say no, just go, all right. So as I said, the transfusions are given to maintain an acceptable hemoglobin, but you have to lose a significant amount of blood and not respond to iron before you'll get to a point where you're transfusion dependent. But if you are at that point where you're needing transfusions, then clearly we have to look at what else we need to do to try and modify the situation, because we can't keep going like this. Clearly the tranexamic acid, the topical medications, and obviously bevacizumab or Avastin has changed the landscape, because now we understand the molecular basis of HHT, and we know that these medications can work. But as with everything, every action has a reaction, no more than the intravenous iron can have side effects that no one necessarily knows about. And so you have to be sure as a doctor that what you're doing is right. And just because you can doesn't mean that you should. And anyone that knows me will know that just because I can doesn't mean I will. And so it's, but as I said, once you need it, you need it. And there are scoring systems. And again, the guidelines are very clear in terms of which patients should be considered and which patients shouldn't. And so it's important that, you know, just because you're not being offered something or it's not given doesn't mean that you won't be offered it in time. But you have to always go, okay, say if you did get the protein losing problems or high blood pressure secondary to it, and then you couldn't. So it's always, you're always trying to make sure that you're not going to make things worse. Because it doesn't last forever. Yes, the bevacizumab may work, but it's not necessarily going to work long term. And no more than anything else, the nosebleeds will potentially come back, the GI bleeding may come back, and sometimes you're better off with a more definitive management procedure surgically or whatever than you are with kind of treatment with other agents. But I do think that, and I'm not going to go through this in detail, but I guess you always have to think in the background, yes, you have to stop the bleeding, manage the anemia, but you also have to try and minimize blood loss so that actually we can try and stop the cycle. And as I said, that can be with your ENT colleagues, with your gastrointestinal colleagues in terms of laser and various different things, and that sometimes is far more effective than a systemic treatment. I guess we're in exciting times, I think, in terms of medications in clinical trials that hopefully will become licensed, and a lot of these are oral and have a more favourable side effect profile, and a lot of them, no more than a lot of things in medicine, have been discovered by chance, in that it's happened that someone has gone on them to treat a kidney cancer who has HHT, and their nosebleeds have stopped, and it's like, oh, isn't that marvellous, and why did that happen? And so I'm not going to dwell on them, but there are lots of medications in train. And so I've alluded to the various things that I guess I get involved in. I haven't really discussed the anticoagulation side of things because I think that's a very niche area, but unfortunately as we all age, we are at increased risk of getting clots in various places. The most important thing is that we can be as healthy as we can be, because if we minimize our risk factors for cardiovascular venous disease, then actually the chances of us getting a clot is much lower, and so prevention is better than cure. And so I guess we should manage iron deficiency. We should not accept low iron stores. We should want and strive for a normal hemoglobin, normal ferritin, normal transferrin saturations, and that way we'll keep ourselves out of trouble. And so whatever you need to do to get to that space is what needs to be done, and that's tranexamic acid, as I said, oral iron and potentially intravenous iron. You may need repeat dosing, and that's fair enough, and as we've discovered, and thankfully in Galway we use Monifer, and it's very good, and it's easy enough to get. But once the ferritin starts to dip and the transferrin saturation stop, you don't need iron that day or that week, but it is time, if you can't tolerate the oral or whatever, to consider it. We have our infusion unit usually in Merlin Park, That's where our patients go to get iron, and it works quite well. There's parking there. It's not as stressful as coming into GUH, which, to be honest, will give you a nosebleed.